Hello, everyone, and welcome. My name is Michael Buckland. I'm the CEO of the McKell Institute, and we're thrilled to be here today with some very exciting guests. I wanted to start by acknowledging that while we come from many different areas around Australia for this forum today, we here acknowledge the Gadigal people of the Eora Nation on which our head office sits. And so we acknowledge their elders past, present, and emerging. One of the things we come here today because one of the things that has been a challenge over the past 2 years, really, during COVID, has been how we manage the emergency needs of the health system to cope with the COVID influx, but also how we address other health needs for the Australian population. One of the things that becomes more acute the longer we live in this post-COVID, or we live with COVID as the new normal. And so one of the things we have been trying to grapple with here at the Institute and with some of our stakeholders and lots of other people in the public policy space has been, what does the health system look like post-COVID? And there's one area that is particularly relevant and has received a bit of debate lately, and that is elective surgeries. Many of us will have followed the women who came out and talked about IVF treatments earlier in the year, but there are many different types of elective surgeries. And just yesterday, the New South Wales Bureau of Health Information found that 3,400 patients are now waiting longer than the clinically recommended time for semi-urgent elective surgeries. And that's the highest on record. And that's something that we need to either accept this is the new normal, or do we need to adjust things? And these are all the questions we want to raise today. And we want to be able to play a productive role in supporting ideas to come forward to policymakers. There is an opportunity for everyone to ask questions at the end of today's discussion. So before I introduce everyone, I'd like to just introduce how you can ask questions. You can use either the chat function, which our colleagues are working through at the moment, and also you can use the Q&A function. We'll endeavour to get through to everyone, but obviously we know that we have a couple of questions, but please don't hesitate to ask. We have 4 guests who represent very different areas of health so that we can explore some of these questions that I've just mentioned. Dr. Omar Khorshid, President of the Australian Medical Association, is an experienced orthopaedic surgeon. He received his medical degree out of the University of Western Australia, but has worked all over the world from Edinburgh to Sydney, and is something of a specialist. And he's really led a lot of the debate lately around elective surgery. And so I welcome Omar. We also have Associate Professor Payal Mukherjee, Chair of the Royal Australian College of Surgeons New South Wales Committee. Her experience is as an adult and paediatric ENT surgeon specialising in ear surgery, cochlear implantation, and lateral skull-based surgery. She sits on many different committees, so I won't go into all of them now, but I would say she's also a member of the Australian Advisory Committee on Medical Devices to the TGA. We're also joined by Pat Garcia, who is the CEO of Catholic Health Australia. They are the largest not-for-profit grouping of health and aged care services in Australia. He is a lawyer and policy expert and a political strategist, so brings a unique lens to these discussions. He's worked for New South Wales premiers and also the Department of Prime Minister and Cabinet. And so we welcome you, Pat. And finally, but not least, we have Sue Martin, Managing Director of Johnson & Johnson Medical Australia and New Zealand. Sue has had a long history with Johnson & Johnson, the largest healthcare company in the world, and has worked in many areas of specialty. In particular, I might mention that she is the executive sponsor of the Global Community Impact across Johnson & Johnson in Australia and New Zealand, and is overseeing the company's reconciliation plan. And so I would like to welcome you all here today. And Sue, I might start with you as the last one I introduced, just because we were talking a little bit earlier and you mentioned that I spoke about the Bureau of Health Information data that came out yesterday, but you have a little bit of research that you've been undertaking that I think is going to be launched tomorrow. Can you take us through this?
Sure can, Michael. Thank you very much. It's great to be on this very esteemed panel for this really, really important issue. And I will give you a sneak peek. This is going to be released tomorrow, but I think it's just so pertinent for what we're going to discuss today. And this was a survey across 2,000 people around metropolitan regional New South Wales to explore the impact of COVID-19 on the health of the community and access to health services. And what we found is, whilst there was a huge satisfaction within ranges of the health system, particularly the nurses, the doctors, the frontline staff who've helped us through this pandemic period, there was a key pain point, Michael. And that key pain point was that people were not happy with the way that elective surgery has performed. In fact, over 60% rated waiting times for elective surgery as poor or very poor, making it the lowest performing aspect evaluated in the health system. And I think this point here is really, really important, that over 80% rated the quality of healthcare as a major concern for them. And this outranked climate change, education, jobs, and employment. So this is a really topical issue that is absolutely front and centre on the minds of our community. Now, clearly, this won't come as a surprise to the healthcare leaders and doctors that I speak to on a regular basis on the challenges of the system. But I do hope that this research, comprehensive research actually, that will be released tomorrow, will be useful for policymakers also to make sure health services are resilient and can continue to provide access to care for all patients. So there's a bit of a snapshot to get the day started, Michael.
Thank you, Sue. And can I throw to you, Omar, and ask, because you've spoken a little bit about, Sue just mentioned that people clearly are caring about not just health, but elective surgery. But you've spoken a little bit about the length of time it's going to take to overcome the, I guess, for lack of a better word, the latent demand and the backlog in elective surgery. Can I ask why are people, if Sue's research is finding that people are so concerned about this area, why, and is it surprising to you?
Well, it's no surprise at all, Michael, and the AMA would certainly agree with the findings that Johnson & Johnson have commissioned from that research. And of course, we're seeing it in polling as well. We've just seen it myself. I've just seen it actually being in South Australia yesterday and experiencing a little bit of that election campaign where health and the performance in particular of public hospitals was very, very high on voters' minds. Now, the reality is that COVID has caused a huge backlog in elective surgery. Estimates around 120,000 mark of procedures that have been delayed. Now, of course, that's not just numbers. That is people whose conditions will continue to worsen, people who may not be able to work and contribute to the economy. And for some people, it could actually affect their survival. So we do have an urgent problem, which will be further compounded by the fact that our system lacks the capacity just to do more, and that includes our private sector. We just don't have thousands of spare beds and spare staff to be able to deliver more healthcare. And of course, we're going to see the consequences of the deferral of diagnostic tests. We're going to see the consequences of long COVID, which may mean that actually those medical patients, the non-surgical patients, continue to push surgery out of our hospitals, further compounding, I guess, the difficulty of this enormous catch-up that we've got to do. So we really need to be talking about the solutions in the medium term, but also in the longer term about how we build capacity into the system so that we can cope with these bumps in the road.
Payal, can I ask you about from a surgeon perspective, and I see you're even in scrubs today, but Omar just mentioned capacity and that's really the key reason we're even talking about this was, and a lot of us supported some sort of restrictions or to make sure that we freed up capacity. Can I ask, from a real frontline perspective, has it been necessary? Do you think it's going to continue to be necessary? And is there a way to avoid it?
I mean, firstly, I just want to say that I agree with everything that, our previous two panelists have said. And it's also ironic that two of the specialties worst affected by elective surgery restrictions happen to be orthopedics and ENT, and I'm an ENT surgeon, Omar's an orthopedic surgeon. With respect to the issues about capacity, I mean, what we're dealing with is worsening inequity in health and access to healthcare. But in speaking from the New South Wales perspective, when the system's just become totally overwhelmed with, COVID, and then primarily it's not even beds, well, it is beds, but we just don't have the workforce. Like at the peak of Omicron, we had 6,000 health workers out of the system. And then on the back of 3 years of, relentless emergencies and crises in New South Wales, we're also seeing a lot of exodus from healthcare workers choosing not to pursue a career in health, especially in the nursing staff. So we're seeing, unprecedented burnout. So when you mention the word capacity, in my mind, that triggers workforce, which is even a worse resource to lose because you can't replenish that quickly. You can't throw money at it. Suddenly you have a workforce. They're very skilled, trained, complex teams, surgical teams. And then, of course, bed capacity. Even without COVID across the world, I mean, I can speak from the New South Wales perspective, but I know that in other states who have less burden of COVID, elective surgery keeps being used as a lever to increase capacity to allow emergencies to occur. And, so there's a bigger question with respect to capacity is in our health system across Australia, do we have capacity to manage current work without COVID? And then how do you build capacity to take on the implication of COVID? And then how do you now, when you go in between the peaks of COVID, you're managing a surge, how do you build capacity to work that at more than 100%, which we don't even know if we can do that with our workforce continually being taken out. But, I think there's three layers to that.
Fantastic. Is there we had a lot of, one part of the way that it seemed that governments were deciding to manage that capacity issue was to look to private or non-profit hospitals, and to use that. Can I ask Pat, dealing with them on a day-to-day basis at Catholic Healthcare Australia, what is how has this experience been from, I guess, that side of the health system? Is it has it been necessary from your perspective? Is there capacity there to do more?
Thanks, Michael. Listen, about 40% of hospitalizations occur in the private hospital system. So it is an integral part of our health system. Most people tend to think of the private hospitals as an appendage to the public hospital system rather than looking at the system as a whole. But I can tell you now that the private hospital system is really under a lot of strain. And that strain comes obviously from COVID, from a lot of the additional costs that come from cross-infection controls, extra PPEs, RAT tests, nurses at the entrances of the hospitals. These costs are significant. So when you do a thing like you suspend elective surgeries, what you're doing is you're strangling the revenue stream for this part of the hospital system. And this is what you're doing at a time when the system is already struggling. So rather than simply using the blunt instrument of suspending elective surgeries, there are different ways that you can ensure there's capacity in the private health system to deal with any surges in COVID infections and to support the public hospital system to ensure that the people stay healthy, but at the same time continue to roll on elective surgeries to keep private hospitals sustainable, to keep patients healthy and safe. One of the things that happened in Queensland recently was rather than suspending elective surgeries, what they did was they reserved a number of beds in private hospitals and said, can you keep those beds free in case we need it? Now, when COVID first hit, I get we need to suspend elective surgeries. No one really knew what was going on. We were seeing what was happening in Italy. We were seeing what was happening in the United States. It caused us all concern. And we very quickly said, okay, let's keep some capacity available in the private hospital system by suspending elective surgeries. We can't do that anymore. What happened in Victoria and New South Wales is we had whole wards of beds fully staffed, not being used for months on end, And when we know that there is a desperate need to keep these elective surgeries ticking along to keep patients safe, keeping whole wards empty for months on end is just not something we can do. So the capacity does exist within the private hospital system to deal with elective surgeries. We just need to be clever about the way we use it.
Can I ask, Pat, given your background also in state and working for Premier's Office and Prime Minister and Cabinet, and feeding a little bit off, so we know the health system is under a strain even now, as we've heard from Payal. We know that the public are concerned about this through the research Johnson & Johnson have done. How does this play out? Do you think that this is going to be a major issue at the federal election in the coming months?
Health is always, a top 3 issue in any state or federal election. So we do know that it's important to the community. And we also know that it's important very personally to every voter. If you can't get the surgery that you need when, within what your doctor says is the clinically recommended timeframe, it bothers you. And if you can't get your child to the surgery they need, or a family member to the surgery that they need within the clinically recommended timeframe, it bothers you. So this hits very personally at people. So absolutely, this is going to be an election issue, particularly knowing that COVID going forward is probably something that we're going to have to deal with for a few years to come. And especially knowing its impact on the health workforce. And everyone knows, a nurse that's under strain, that's been working for 2 years nonstop and never had a holiday, and the obvious costs that the hospital system has had to incur because of that.
Omar, picking up on some of this as well, the 2 streams that seem to come to mind from the comments so far are really both an acknowledgement that yes, there are still capacity issues that we need to address, but also that we cannot almost continue to just sacrifice one area of health for another. Can I ask how do you balance those 2 streams, or have I got it wrong? Are they not competing as much as I'm picking up?
Unfortunately, Michael, they are competing. That is the reality. We're seeing it in my home state of WA at the moment, facing our first experience with COVID, and elective surgery is just shut in the public sector, and it's about to do the same in the private sector. And again, we're all scratching our heads wondering, what are these private facilities going to be used for? How are they going to contribute to the great effort of looking after the health of Western Australians when in fact they're going to have nothing to do? Now, in the public side, we have to acknowledge that the capacity is not there. We don't have the beds, we don't have the staff. And so we are having to focus on the sicker patients and recognise the staffing issues, as Payal has mentioned. So it actually does make sense, even though, as a surgeon who works also in the public sector, it's hard to know that our patients are going to be the ones that suffer where others are getting looked after. But at the end of the day, we have to acknowledge some of the work we do is less urgent, and we have to look after those people coming in through the front door of the emergency department. But if you are going to have to slow down elective surgery in the public, it should be done to the minimum level possible to minimise the effect of that, to minimise the number of people whose care is deferred, and to keep those teams working if there is capacity. But similarly, on the private side, we shouldn't be having statewide arbitrary decisions made by, and I'm going to be a little bit blunt here, but power-hungry premiers and chief health officers who've gotten used to telling everyone what to do. I don't know why. Like, shouldn't you say, as has been suggested by Pat in the Queensland example, look, we'd like to be able to access a ward in your hospital if we need it. Can you commit to giving us that ward with 2 days notice or 3 days notice if we need it? And a private operator can empty out a surgical ward pretty quickly if they need to. And you could just let surgery keep going in the private. And in fact, you could look after some of those public patients in the private hospital if you've got the arrangements in place. But too often that hasn't happened. And so that impact of COVID is felt disproportionately among surgical patients. It's felt by the private hospitals, as Pat has very articulately laid out for us. And we're going to face this problem for months and years to come because we don't have, once we are back to normal, we don't have that extra capacity to go above 100% for a sustained period in order to catch up with this work that hasn't been done.
I mean, that's a really interesting point. And I'm going to throw to you, Payal, again, if I can, about that wait list, that backlog is not going away. So it's going to come at some point and it's going to need to be addressed. And you're talking about burnout and these things from the workforce. Do we need to be looking at better workforce planning? I mean, the COVID's not going away. We're in year 3 now. Do we need to expand public hospital capacity generally so that it doesn't need to rely on the private hospital system? Do we need to have a concerted effort to expand the workforce? From your point of view, what are the avenues forward do you see?
Yeah, look, I think, firstly, one of the things about the pandemic is that each crisis in the last 3 years has brought unique challenges. And one of the good things in all of this is that the ability to pivot and learn from this has drawn a lot of collaborations. And one of the things that the situation we're at now is absolutely we've learned that our workforce cannot be replenished and we need to work on our workforce. And we need to look at long-term strategies of replenishing the workforce. I mean, speaking, from the point of view of with my RACS chair hat on, we know that every time elective surgery stopped, it also impacts training. And if you do it enough times and repeated amount of times, although state health services are controlling the surgical services workforce training actually happens at a federal level. And if you don't have the same quality of workforce available, each year we need to make sure the exams are going on and, then the people who are coming through actually then get to contribute in the public sector. So if we don't have that planning and, if it's all of this disjointed by the states, there's actually no national plan to make sure that that workforce supply is being coordinated by the workforce. The workforce are going in an appropriate place. So appropriate workforce present in an appropriate geography. So there is a lot of workforce planning that needs to be done. And, these are things that we're doing all the time, but it's not easy. And it's not easy because each variant, each disruption of COVID is coming faster. It's more disruptive than the other. So just before you've had time to recalibrate and make a plan, you're being disrupted yet again. And if it's not COVID, then it's a flood or a fire or something or the other. So speaking from a constant crisis management plan point of view, it is very disruptive. So, I completely agree. We do need a workforce plan, but it's not just having a long-term plan in the workforce and increase the workforce in the public sector, but it's also making sure that that workforce is representative of the clinical needs. So we have the right workforce in the right geography, such as in rural health, such as in areas that have been worst hit by Delta, like poor socioeconomic areas. But we also then need a national interest by the federal government to be interested in elective surgery and make sure that there's some harmonisation, that it's not just all being done ad hoc by the state, because we can't build the two bits of pieces together.
That's very interesting. If the call for some national planning is needed, and to use Omar's lovely turn of phrase, power hungry premiers, I might throw and ask, is that possible? Is it possible to get that kind of coordination at the moment? I'm going to throw to you, Sue, because you work with all the different hospital systems. Do you see, were things like National Cabinet working from an industry perspective in this space? Do you have hope that this kind of national planning can occur, or do you think that we've got to kind of get used to states leading the way on some of these things?
Look, Mark, I would say this is a national problem. We've heard it really clearly today, right? And so doing it on an ad hoc nature is not going to solve this national problem, but there does need to be cooperation between the states and federally. This was clear in the research. The community is telling us that this power struggle, this is not creating solutions for elective surgery. And really, that is the problem to be fixed. Now, one thing I will say, however, we do have an industry covered right here, whether it be through surgeons, through hospitals, through industries. There are multiple stakeholders, insurers included, that need to be part of this solution with government. I think what we're really trying to say that any type of these decisions should be made in consultation with all of the stakeholders that can potentially minimise some of this huge impact to patients, which is the reason why we're in this industry in the first place. And the stories I've been hearing, Michael, about patients, and Payal and Omar, I'm sure, have heard many more than I have. These are real people having real impacts, yet PATS hospitals are lying idle. So there are other instruments, there are other policy solutions, and there are better ways that as industry we can also use and promote the use of technology in a clinical safe way to really advance patient care. Because just the one last thing, whilst COVID has created this conversation, whilst COVID has created this blunt instrument, we have an ageing population. We have an increased burden of chronic disease. This is not going away. We do need a longer term solution for a sustainable healthcare system, both across the public and private healthcare sector.
It's interesting you mentioned that everyone's together, and I'm picking that even though there seems to be a bit of difference in maybe the emphasis of some concerns between you, there is a general view that something needs to be done. I mean, I'm asking, what's the barrier here? What is stopping? Like, is it a policymakers just needing to, they have to overcome some caution, or is it, what is the barrier to fixing this or taking action?
Look, I think that there are multiple, Michael. It's if there is no silver bullet, let me put it this way, and if it was easy to solve, it would have been solved. I would like to think that greater collaboration between the states where this question actually started is possibly one area that can absolutely improve. I think greater consultation with all of the stakeholders who do have a binding intent, and that intent is to treat patients. That intent is to ensure we have a sustainable healthcare system. And our community, through the research results, they're telling us this, right? They are absolutely resolute in ensuring that we put together solutions and policies that create a sustainable system.
So if I can go back to you, Omar, and ask I'd like to get into some, I guess, really constructive ideas into, we talk a bit about whose fault it is here and who's where the barriers are. But I guess if we're here to support people who are, and I'm hearing out of all the health systems that there's sort of an effort or energy. Have you got any sort of concrete ideas or principles that we need to get through, a bit like Payal's mention of the sort of maybe a national workforce plan? What is it from the AMA's perspective?
Have you got an hour, Michael? We've got lots of ideas. One thing I was pleased to put out at the press club last year was our vision for Australia's health, which actually does lay out some concrete, achievable, simple things that can be done right across the health system to improve its sustainability. Because we certainly agree with Sue that we have very foreseeable clouds on the horizon. There is no doubt, forget COVID, there is no doubt that our health system is going to get harder and harder to run, more and more expensive to run, and we need to have reform conversations, and we need to have funding conversations now in order to prepare for that future. And unfortunately, reform with our system of government, with our split responsibilities for health, is difficult. It is really difficult. And most of the reforms that are done are very, very small reforms. What we need is big reforms. But I'll give you a couple of specific ideas. So around private health sustainability, we think that the affordability of private health insurance is going to be an increasing problem. Up until COVID, we had 20 consecutive quarters of a drop in the proportion of Australians who had private health insurance. And that says that the affordability is a concern, particularly with low wage growth amongst younger Australians. And the more younger Australians drop out of health insurance, the more the premiums go up, because the people who are left are the ones who are more likely to claim. And with our very fair private health insurance system, it'll just get more and more expensive. So we put out a prescription for private health insurance, which talks about some of the levers that government can pull right now. Very simple, doesn't cost much money. The only one that with any real budgetary implication would be restoring the 30% rebate to 30%. But otherwise, looking at lifetime health cover, looking at the Medicare levy surcharge, tweaking those levers that have worked in the past, is likely to go some way to improving the sustainability of that part of our health system and make sure that Australians can afford their insurance, because the public hospitals are a much harder problem. And our idea there is for there to be really 4 main thrusts to reform. One of them, of course, is to look at the funding amount and the way that it is done. We believe that the government should be the federal government should be paying 50% of the cost, so that they can't claim that public hospitals are a state issue anymore. It's a collaboration, and the funding should be a collaboration. And we believe that the cap that the Commonwealth has in place on expenditure on public hospitals should be removed. That's a $20 billion over 4-year cost. It's not small money, but it's the kind of change needed to make a difference to public hospitals. But at the same time, we've got to look at how they perform. At the moment, we're not measuring health outcomes and the way the public hospitals perform. We're only looking at how much throughput there is and how much they're paying for it, but not the actual performance. We've also got to look at keeping people out of hospital. And this is another key area where you can look outside both private and public hospitals at reducing demand through better primary care and better aged care. So, all of those are really tough reforms. All of those require investment, and in particular, public hospitals require a large amount of investment. But if we don't have these conversations, we're going to be far worse off if we're having this chat again in 5 years' time.
Thank you very much. And I do see, I'm just making one last call out because in a few minutes we'll be able to get to our Q&A before we finish up. But just for both Payal and then Pat, we have I saw, Payal, you nodding your head about the 50-50 funding. I think I saw that. And also I wonder whether preventative health, which is I think where Omar was really going with this, looking at other ways to sort of address reform, is that perhaps almost one of the forgotten things in addressing your burnout concerns for the workforce?
Yeah, look, I mean, Omar's touched on so many really key points, which, I agree with. And in New South Wales, I believe governments across in different states, all in their own way, you're sort of looking at surgical reform and value-based care. How do you improve efficiency? And that's not just about sort of reducing surgery where surgery can be reduced, but making sure that we look at everything from procurement, to reduce the cost variability, to make sure that we're having, we've got safe surgeons and safe surgical practices, improve the care model so things are more efficient. But it also includes things like funding or changing funding models, which support the care model. So, for example, if we can look at, outpatient-based services, so outpatient-based procedures, those procedures then need to be reimbursed through Medicare to be able to incentivize people to take it up. Otherwise, every time, if you're not going to be able to reimburse, you just put that on an operating list. But surgical technology and practices have changed, but, Medicare hasn't really changed this practice for a long time. So that's why there's this coordination between state-based systems where you're like, for example, for us, we know that ENT surgery and ophthalmology bounce back a lot easier from data from back from 2020, from our 2020 catch-up, alpha catch-up. But we know orthopedics doesn't catch up so quickly because they need at least 3 days in hospital after a hip or knee replacement. So what as a state, between, you know, collaboration between clinicians and policymakers, we're looking at is, can we change the care models for orthopedic care so we can have better prehab and better rehab, but perhaps look at day surgery orthopedics. I mean, these are innovations, but if the funding system in the hospital is biased towards having long, complex hospital stays, we're never going to have successful change. And that's why all of these stakeholders need to be at the table to make sure that we incentivize a lean surgical program. And that's how we can build, you know, get 120% of surgical services through 100% of capacity.
Apollo asks, and I might throw this one to Pat to get us started, but he's really asking about whether delays in elective surgery waiting lists are methods by which state governments are using to control costs, perhaps not just capacity issues. Can I ask whether that's something that has come up?
Thanks, Michael. I'm not sure about that. I wouldn't want to think that. I do think there is a lot of political pressure on governments and ministers to try and keep elective surgery waiting lists down as low as possible. So we do get the sense there is good intention there. I think the bigger problem comes from two things: a lack of understanding within the public sector about how the private hospital sector works. And a lack of planning, and planning has been mentioned by all of our panelists today. We shouldn't be turning off and on the elective surgery tap with private hospitals, reacting to things as they come. Realistically, there should be a 5-year plan about how to tackle elective surgeries, and agreements should be made with the private health sector about how to deal with it, what capacity there is to deal with it and do it incrementally over a period of time. And that's how you tackle elective waiting surgery lists. Not, it's gone up this month, so we're going to try and tackle one particular type. And then there's problems now with COVID, so we're going to try and get the private hospitals to do it in the period of January to February. You do need to plan these things out. And if you plan these things out, you give certainty to the sector about how to utilize its resources, how to better manage its workforce, because, yeah, like Payal said, workforce is clearly an issue as well. So planning, better relationships, better understanding and knowledge transfer, I think will significantly help this problem.
Throwing to Sue and then Omar, Anonymous asks whether you've had conversations with government about these pauses and what their views are at the moment. So could I start with Sue and then we'll ask Omar from his perspective?
Thanks, Michael. So I'm sure Omar has had far more in-depth conversations with government, but certainly in regards to industry, this has had a major impact to multiple stakeholders. Pat, as he spoke about earlier, also to the med tech industry, but it's really in regards to the discussions have been about the bluntness of the instrument, making sure that we can be more nuanced in our decision making in regards to elective surgery first and foremost. But I think it's also about the role that all of us as stakeholders can play in finding these solutions. I mean, Omar has just outlined a significant plan on behalf of the AMA. Payal has spoken about various policy scenarios, whether that be through length of stay. Obviously, from an industry perspective, we're always looking at where it's clinically appropriate. How do we use digital technology to reduce hospitalizations or enable care from home outside of the hospital where it is clinically appropriate? So yes is the answer. There have been discussions, but I think that now the timing is right to really elevate, escalate those discussions and really move into some concrete actions.
Thanks. So I'll just follow up. I might actually start with a slightly different question, just going back to Polo, who raised the elective surgery categorisation guidelines, because I think that's been another learning from COVID that, a couple of issues here. Firstly, that it really has never been applied to the private sector before. Surgeons have control over their list. They do people when they choose to, and the hospitals facilitate that. And all of a sudden, you're asking hospitals to play a role as a gatekeeper, potentially, to make sure surgeons are categorising people properly. And of course, you're applying categorisations. They've just never been used in the private sector in this context. And when you look at the categorisations themselves, is it reasonable in this so-called rich country in which we live that somebody with a painful condition like a hip or a knee replacement, or somebody who needs a cataract to be able to see and drive, that they should wait a year for their operation? Is a target of a year a reasonable target for a modern healthcare system that's designed to get people back to their normal quality of life and get people back into employment and functioning? It seems to me that there are some major deficiencies in that, and I think that's something that we will be looking at in the future, hopefully in collaboration with the College of Surgeons, because I think there's been some learnings there. In terms of chats with health ministers, as you know, the AMA talks all the time to health ministers in each state and, of course, federally. The federal government have had no part to play in these closures in each state, but I have had a chat with Greg Hunt about what he can do to help the hospitals deal with the backlog. And that was a good conversation, but we haven't seen any firm announcements as yet as to whether there might be any short-term funding to assist with that. In each state and territory, both the College of Surgeons and the AMA have made representations to say, look, we understand why you're doing this, particularly in the public hospitals, but patients needing surgery have a right to their medical procedure just as much as a patient who needs to come into the front door. My internet says it's unstable. I hope you can still hear me. And really to not to, I guess, decrease the value of elective surgery. And one final learning, I think, has been this term elective surgery. And maybe it's the wrong term because it implies that we don't have to do it. Now, these are essential surgeries in almost every case. So maybe we need a better word like planned surgery because we're planning that admission as opposed to unplanned. But elective does just give this impression that it can be the first thing to be discarded when the health system's under pressure. And health system under pressure, we've got to get used to that because that's our future.
Payal, I want to direct this next one to you, and it's really two questions from Kate, but it starts to look at how our response maybe needs to look at the role of other models of care, so primary and secondary healthcare sectors in reducing demand for the tertiary. It goes a little bit to what you had said earlier. And then just to kind of wrap in the other question from Kate, which is a very good one, is whether the current levels of investment are just not enough to allow people to, Omar just said, a supposedly rich country, people having to wait longer than a year. Maybe this is just a matter of money. Like maybe we do need to realise that we're going to need to pay more. Can I ask on those two questions?
Yeah, sure. So, I mean, I think, look, models of care do need to be reinvented. I think, what I alluded to, one of the benefits about a crisis is everybody's prepared for change. And sometimes, if you haven't, if big systems, big complex systems are resistant to change in general. So we should see that as an advantage of COVID, that it's making us change and change quickly because as I said, each wave of COVID brings different challenges. The problem, however, is if, one state is doing something, they're actually not learning from, the failures and the successes of another state. So we're not learning as a system. And as we, said many times, that the health system it is a national system, it's state run, but we do need that, collaboration. So, all the work that we're doing in changing models of care, in managing, having more efficient outpatients, and prehab and rehab. After that, that's, if there's some positive that comes out of that, that may not be translated to, say, Victoria, or and vice versa. Something might have happened in another state, and that doesn't come across. So it just means there's a duplication of cost and a duplication of effort, a duplication of time, and everyone learns slower. So, and the pandemic is not like that. It's hitting you constantly. So I think that's really important. And as respect to your second question, so that was about health investment. Look, I think, it is important to have investment, but we need to, it's not just about throwing money, but we actually need to make sure that there's all the stakeholders in there, so that money is, it's value for dollar. We can't just keep doing the same things that we did. And even, what worked in Alpha is not going to work in Omicron. We don't have the workforce. We still have workforce attrition. So it's just, you can't even do 100% of operating without knowing your anaesthetist or your registrar tomorrow is going to be available, not going to be quarantined. So these challenges are unique. And unless we are really collaborating and very agile in our methods, the investment that we put in there is not going to be wisely spent. So we need long-term strategies, we need money, but we also need collaboration.
Fantastic. And I might not to drill you too hard, but to stick with you for a moment about with this next question, and it's sort of a personal one for me too. My wife's a nurse in a public hospital and has been dealt with something many of the other nurses have done as well. But I ask about, you mentioned burnout and you mentioned resources, workforce planning, particularly among nursing staff. You highlighted that earlier in your answers. And so we have a question from Brett asking about whether that might be a impetus towards supporting campaigns for nurse to patient ratios and those kind of interventions. Can I ask what your view is and whether that's something you support?
Yeah, look, I mean, firstly, we have to make sure that, nursing staff are supported. One of the problems with one of the problems is you've already had, they're already a pretty stretched resource, our nursing colleagues. And on top of that, there's not really been, a significant amount of increased reimbursement for their salaries. But during COVID, particularly Delta, which was quite, it wasn't just people were getting infected and therefore had to quarantine, but we had to have a huge amount of deployment to support mass vaccination. So those two levers just meant people were seeing, terrible things in hospitals and having to deal with, people having to quarantine amongst their peers as well as their patients. And to see the impact of people dying, it's traumatic. And even at the end of Delta and New South Wales, we found that nursing staff were choosing not to be in medicine, which was really sad. And then, we've just had, another crisis on top of that. So look, I think investment in nursing, boosting the nursing workforce is important. All of this is being done at a time where we don't have people coming in, so there's limited immigration, so we don't have that agile workforce. So therefore, we do actually have to have a more resilient system because we don't know if that's going to be enough to cap it.
Thank you. And Pat, I've got a question from another Pat asking about day surgery. He says it appears that there's been pressure to move to day surgery during COVID resource pressures. Is this a legitimate strategy? Is there sufficient community-based care to allow for safe recovery at home?
Oh, I do think.
If I can ask that of Pat.
Yeah, I do think out of hospital care is an important element to the future of our healthcare. And working out the right funding mechanisms in the private health system for that will be really important. Obviously, it's a little bit easier to do out of hospital care in the public system, and I see that that's occurring now. I know that there's a joint venture in South Australia between one of our members and Insure Calgary to provide out of hospital care in South Australia and in Adelaide, and I think that's a wonderful new development. But working out funding models in the private sector would be really important for us to move to that sort of system. I do think there are lots of different ways that the private health system can look after, and the public health system can look after community health. It's funny because we're talking primarily about the acute health system at the moment, and you're right, we should be talking about community health, we should be talking about primary care. we should be talking about aged care, because all the systems are interrelated. So, for example, nursing shortages that occur in the public and private hospital systems have a downstream impact on aged care, who also needs RNs. So if there's a lot of pressure for hospitals to acquire whatever nurses are available, that puts pressure on aged care who can't then provide the care, subacute care, and residential aged care that's required for their residents. So looking at an integrated approach to the care of the community, where you integrate primary care and community care and acute care and subacute care and aged care, is really important and the way of the future. And the more thinking that goes on about that, the better.
Thank you, Pat. Rosalina asks, and I'd like Sue's perspective on this, coming from a major global player, I guess, in this space, and ask whether there are maybe some lessons in what's going on in other jurisdictions in how to manage elective surgeries during COVID. Do you have sort of any insights into that across from your perspective as a global company?
Yeah, look, this is a great question from Rosalina, and we're constantly working with our global colleagues to truly understand, are there learnings in other countries and other markets that we can adopt? I think that whilst there has no perfect solution, let me start with that as a premise. There has been no perfect solution. I think that countries that have managed this better have tended to be more nuanced in their response. And this is where it's just been such a critical thing for us here in Australia, is it has just been very severe in regards to what has been required or what has occurred. Now, whilst that was necessary at the start of the pandemic, to still be doing that now, 2 and a bit years later, is probably where we are not keeping up with other countries around the world. So it is, again, there is no perfect answer, but I will definitely say, just in regards to the investment that's made in health, and countries that see health as an investment as opposed to a cost, are definitely looking at this through a very different lens.
Thank you, Sue. I'm conscious of time, but we do have a couple of other questions, and especially this one I thought was particularly interesting from Omar. I'd like to get, what are the consequences if we don't clear the backlog? What are the consequences if we just say, well, you know what, maybe the new normal is we have to get used to sacrificing some things in exchange for dealing with the acute care needs associated with COVID. What happens if we don't do it? Why is that a bad thing?
We'll pay a price for not looking after the health of our community, and that price will be a declining quality of life. It may be declining life expectancy, and at the moment we're at the top of the pile in terms of health systems when it comes to our ability to prolong life and to keep people healthy. But that position can't be taken for granted, and if we can't perform elective surgery procedures when we need to, then people won't be able to work, or they won't be able to contribute as they normally would to their family life or whatever it is. In terms of diagnostic procedures, well, we can easily foresee a situation where cancers are picked up too late to be cured, and all of a sudden we've either got a death, or we've got somebody who could have been cured by surgery and instead faces rounds of chemotherapy, radiotherapy, which is of course at a much greater cost to the community and with worse health outcomes. So this is important stuff. These are conversations we have to have, and I think the population during COVID has made it very clear that they do value health. They are willing to make sacrifices to support not just their own health, but other people's health. Now that conversation's got a bit more difficult as the pandemic's aged a little, and as we've got to the 2-year mark and everyone wants to take their masks off. But I think when it came to the crunch, Australians did what they needed to do. And our view is that Australians are willing to pay more for healthcare if they can be guaranteed that money won't be wasted by governments or pork barreled or anything like that. If they knew it was going to be properly invested, or ideally they have control over it themselves, then I think Australians are willing to invest in healthcare, and that's what governments have got to do too.
Can I just
Thank you very much.
comment?
Oh, go on.
Just following on from Sue and what Omar said, internationally, the other countries are seeing, they are seeing complications of delayed care as well. So, like for example, in Canada, they've seen 20% less breast cancer presentation. So, COVID's not just accidentally cured breast cancer, but people are presenting late. So it's not like we're expecting to see it around the world. We are seeing the complications of delayed care. The positive also is that, whilst we have, a problem in Australia, we also have a smaller population. So compared to, somewhere in the UK where the elective surgery backlog is so big, we can actually do this if we do work together. That's the positive.
Well, I'm always an optimist, so I quite like a bit of a positive note. Thank you. And I might just, with time running out, I would like to just give everyone a final opportunity to just leave a message, but also if I can wrap in a couple final questions that we didn't get to, and just if it's something that is of interest to you or part of it. But one is, which state's done the best on this? Do we have a best practice? Another is, what is the role of medical technology in supporting changes to these things? And finally, what is the message you would give that you think the policymakers need to be left with? And just while we're with you, Payal, I might start with you, and then we'll go to Omar, Pat, and Sue, and then wrap up. But thank you.
I'd like to think that New South Wales done the best. It's not the worst, but I think I'm really, really thankful for all my colleagues in policy and also in politics. We've seen tremendous collaboration, and we've, right from Alpha, when we had a roundtable in the state, the government actually called for and organised the work that we've done through Alpha. We're ready to roll that out in changes right now. So I'm not saying that it's perfect, but I do think I just want to extend that gratitude. And sorry, what was your next question? You're on mute, Michael, sorry.
Sorry, there's just it was just if you wanted to make a comment, we have some other questions around the role of technology and and whether one's.
Yeah, and then, responsible use of technology, it's one lever. We absolutely need to embrace it. So I'll give the others an opportunity to refute my point of view.
I guess I'll go next then. So look, I completely agree that technology is part of the solution, both in terms of, in surgery, new technologies may well lead to better outcomes and shorter length of stay in hospital, our ability to transform multi-day cases into day cases and so on, but also in terms of an investment in connecting our health system up better, having our health information systems properly joined up is a huge challenge. But if we can ever get that right, it'll have a transformative effect on the health system. In terms of messages, I think the one I'd like to leave is just that COVID has taught us so much. And one of the things we learned very early on is that we can make very big changes very quickly when we need to. And unfortunately, whilst we did great things in that first year, things have started to slow down. They've ground to a halt. We're back to the normal pattern of reform is hard. You don't win elections by reforming. And in fact, our two parties at the moment don't seem to think that health is going to be much of a battleground. Well, I think we've got news for them. Watching what's happening in South Australia and looking at repeated polling says that health is important to Australians, but we want to see governments not just investing, but opening their minds to reform so that we can all get together as an industry, as you can hear that the agreement that we have around the table here today. Let's turn that into some concrete reforms that can actually take us down this path of addressing the sustainability issues and, of course, attracting the funding that we need to make sure we prepare both our private and our public systems for the challenge that we can all see crystal clear, that governments know are happening, the general public know that these challenges are coming. They're very aware of it, and any party that has no health platform that addresses these issues going forwards are going to really struggle to win our next election.
All right, let me go next really quickly. Yeah, so we mentioned before the Queensland government's approach to the Omicron surge, and we said that their approach about suspension of, we'll call it planned surgeries, was excellent. One of the things that was part of that was they made sure that each private hospital was aware of who the referring hospital network was. So the public hospital that would be referring COVID-infected patients to the private hospital were in constant weekly communication with the private hospital, letting the private hospital know what their capacity was, what they were seeing on the ground, so that if they needed the 25 beds that they'd reserved, they would use it. Otherwise, the 25 beds could be used for elective surgeries. What I love about that, and I think is the future of our sector, is ensuring that there is relationships that exist between everyone in the health system. The more people talk, the more people plan, the better we'll be able to utilize our system more effectively, and we won't have to use blunt instruments like suspension of planned surgeries.
And Sue.
And finally, maybe I'll just finish where I started. Healthcare is a major issue. Elective surgery is a major issue. In fact, the community is telling us that it's outranking climate change, education, jobs and employment. So mark my words, people are very concerned about elective surgery and very concerned about healthcare. And I'm encouraged and in fact committed, working with all the various stakeholders, not only here on this panel today, but even more broadly, that we can come to collective action, collective reform, because the health of Australians depend on it.
Thank you, Sue, and thank you to all of our panelists for joining us today. It's been an absolute pleasure. I also, on behalf of all of us, want to thank the health workers, the nurses, the doctors, the surgeons, and all the researchers working on the vaccines and everything else that have had to go through so much over the last 2 years. We have these discussions to promote solutions and to be part of making the system work better. And so we thank all of them. Finally, I want to thank everyone at home for joining us today. We appreciate all the questions that have come through and apologies if we weren't able to get to them. But all the best, and we will talk soon.